All right, I wanted to provide a resource here of nursing home survey deficiencies, and these are deficiencies within the state of Minnesota that have come up in early 2018 here already. So I didn't notice any obvious identifiable trends or anything that deviate from past deficiencies as far as medications go. But yeah, I want to run you through some of the examples that I came across. So first one here, I've seen this deficiency plenty of times before. We've got a hold parameter in place for a beta blocker that reduces pulse, and the order was written to hold a Atenolol dose if the pulse was less than 60. Well, in our EMR, there was no documentation that we were checking this pulse on a daily basis before giving this medication. And, that's typically fine for beta blockers. I mean, there's so many patients where we don't check the pulse. The provider doing this or asking for this maybe did have a concern with a lower pulse or something at one point. And this is a good reminder to staff as well as consultant pharmacists. If their pulse is fine, get rid of that hold parameter. I mean, there's no reason to take the time to check it on a daily basis if it's not necessary and if their pulse is excellent. And if it's been consistent, even more so there. So, because they had this order to check pulse, it wasn't done by nursing as it should have been, or it wasn't documented by nursing as it should have been. Either way, and the pharmacist didn't recognize it either that the nursing wasn't doing this. F329 unnecessary med, as well as pharmacist failure to notify 428 was given. Now, in this clinical situation, the pulse did dip below 60 occasionally when it was checked, and they also gave it, even when they had a pulse of 58 as well. So, important to keep those parameters in mind, and if there's things on the MAR that staff are supposed to do within the orders, they better be doing it, or it's an easy kind of survey deficiency to give here. Now, like I said, in this situation, I probably would have asked to remove that hold parameter if the pulse was stable, the patient was clinically stable, and who knows, I didn't get into the details on this for how long that hold parameter had been in effect, but maybe this was on for a year. I've definitely seen cases where it gets put on and it just gets left for forever and nobody looks at it. And, nurses are stuck with documenting pulse every time they have to give this Atenolol dose. So a few different things that could have been done to prevent this, but a good learning lesson here. F431, so this is a storage one. I mean, this is a no-brainer, easy deficiency. It's a hard one to catch as a consultant pharmacist, other than identifying trends and letting staff know about it. But odds are likely if surveyors found one, the folks at the facility likely maybe are a little bit sloppy on dating of insulins and getting them out of the cart when they are past their beyond use date. Example here, 329, risperidone for restlessness, agitation, and wandering PRN. Really try to avoid using those descriptive terms. It's not an indication for an antipsychotic. They also had a trazodone on board as well, kind of for similar type symptoms. Both were being given at different times. And in addition, they never documented non-drug interventions prior to giving the medication, and that's a big no-no. Now, in 99% of cases, maybe 90% of cases, staff are doing non-drug interventions, are trying to redirect that resident, are trying to give them some comfort, see if they need to go to the bathroom, and so on and so forth. But the challenge is getting that documentation in place. And that will lead to deficiencies, certainly if you don't have the documentation. But so I had a couple strikes going against him here. The indication and then the documentation apparently wasn't very good either. 329, 428 here, excessive dose. Facility policy, standing orders were to not give above acetaminophen 3,000 milligrams per day. Now, there was a push, definitely several years ago, to maybe try to limit geriatric patients to 3,000 milligrams per day. Some people still maybe agree with that. Others think 4,000 is totally fine. If you're going to implement 3,000 milligrams of acetaminophen per day, you definitely need to be sure staff is aware, and also be aware of that it's going to say that on the MAR, and we can't go above that. So this was a pretty easy deficiency where staff was going above what was recommended in the medical record on this patient, this resident. So they got a deficiency for unnecessary med, and the consultant pharmacist didn't catch it either, so they double dipped them with 2 tags there. Another F329, duplicate analgesics, and we didn't have parameters for use. So here we actually had 3 analgesics, acetaminophen versus tramadol versus ibuprofen. Which one do you use? And different staff were, likely using different agents just based upon whatever they felt like was most appropriate there. So make sure you've got a solid pain scale association with giving medications in a long-term care facility, or eliminate the possibility and go with what the patient uses. If the patient uses acetaminophen most of the time and it works well, just get rid of the other 2 medications and discontinue them. So a few different ways to kind of tackle that, but you really got to have defined kind of criteria as to which medication should be given in which type of situation. F431, so again, insulin pens. This isn't necessarily an expired insulin pen, but we don't have a label on it. So we've got risk for inappropriate use, maybe grabbing it for a different resident, because we don't have a name or any type of labeling on that pen or the instructions there as well. So their fix was to obviously alert the dispensing pharmacy and say, hey, we need labels on all these insulin pens to ensure best practice, and that nurses can compare the pen that they're giving to the MAR and so on and so forth. Here was another one with a mood stabilizer, and carbamazepine is a jack of all trades. It can be used for a few different things. And in this case, it was really hard to tell from the medical records what the medication was being used for. So the provider was documenting that this was being used for behaviors, and staff was monitoring for seizure-related concerns and issue because it is an anti-epileptic medication. And so again, just getting on the same page, recognizing that meds need to have a diagnosis, we need to know what we're using them for, and we need to get that figured out when a new resident presents to a facility and get all our ducks in a row. And pharmacists failed to catch this as well, and didn't recognize that there were issues as far as the diagnosis and clarity and the appropriate monitoring that needed to be done there. Just want to point out a resource if you're a consultant pharmacist, if you're an aspiring consultant pharmacist. Definitely I've created a resource to help explain kind of the ins and outs of the long-term care consulting world, what we do as a consultant pharmacist. I've got over 10 hours of kind of recorded videos that you can certainly check out anywhere from survey things to psych meds to my process and what I look at when I'm reviewing a resident's medications and chart. So that resource is there. Just Google Insider's Guide to LTC Consulting, meded101.com, and you'll certainly find it. So hope that provides a good resource out there for you, and hope you enjoyed the update on some hot off the press 2018 survey deficiencies in long-term care.